most clinicians have never been trained to raise these issues, and it's hard to do it well, and it's easy to do it badly. Like, you wouldn't want to come out and say, you know you're dying, right? That wouldn't be helpful, right? But doctors have had zero training, for the most part, in how do you approach these conversations. And one of the core principles of palliative care that needs to be embedded in all of medical and nursing education is listening to what is most important to our patient and the family, and asking and being genuinely curious about their inner life and what matters most to them. And in doing that, these issues will arise naturally. So, for example, if you were my patient and had a progressive disease, and all we've been talking about is what's the next chemotherapy regimen we can try, but it's becoming clear we're on the third round and we're not getting a great response, and there are probably more experimental things we can try, but it's starting to be clear that this disease is not going to go away, right? So I would open it by asking if it's okay. Is it okay with you if we talk a little bit about how things are going with your illness, right? Now, 95% of people say, yes, doctor, I want to talk about that. 5% do not want to talk about it and say, no, that is my oldest son's responsibility. In my family, those decisions and that information belongs with the oldest son. Very important to know that. If I impose information on you that you don't feel is appropriate for you to have, that you don't want to have, that breaks some kind of cultural standard for you, you will never trust me again. So, do you want to talk about this? Do I have your permission to begin this conversation? And then the next question is, are you the kind of person that likes to know the details about your illness, or do you prefer a more general outline, or would you rather I talk to someone in your family? So some people will say right away, don't tell me if my cancer's worse when you say that. They know exactly what you're getting at. And other people will say, well, actually, my oldest son makes all the decisions, so let's arrange for him to come and talk to you. And I don't really want to know anymore. But that's the minority, but it's a true minority, and particularly true in some minority populations in this country, that the truth is not an unalloyed good. But say it's the 95% of people who do want to know and say, yeah, please tell me. Then the next question is, tell me about your understanding of your illness now. And what have your other doctors told you? Because most people with a serious illness, especially if they've been in a hospital, have seen many, many other clinicians. Interns, residents, other oncologists. I'm the office oncologist. You're in my office. But when you're in the hospital, I don't see you. Other people see you, and I have no idea what they said to you or what you interpreted from what they said to you. So if you come back and say to me, yeah, the doctor in the hospital told me that my kidney function was much better, and he was really optimistic about it. And that happens all the time, right? Because maybe your kidney function is better. It has nothing to do with your future, because your cancer is determining your future. But imagine how a regular person would interpret that. That's good news. I'm getting better, right? On the other hand, if you said back to me, I spoke to the radiologist after my last PET scan, and he, it's clear that the cancer is progressing in spite of this new chemotherapy you're giving me. Two completely different conversations, right? And I haven't told you a thing. All I've done is ask you questions. Right? Without knowing where you are at the beginning of this conversation, I can't possibly offer information that might be helpful to you at that point. So say you say the latter thing, like, I know my disease is progressing. I then ask permission to give my opinion of the situation. Would it be okay if I expressed my understanding of the current state of your disease? And then say you said yes at that point. Then I'd say, unfortunately, what you heard from the radiologist, and I'd start with unfortunately, because what does that do? That allows you to prepare. That's what we call the warning shot. Unfortunately, what the radiologist and you discussed is true. Your cancer appears to be progressing in spite of this new chemotherapy that we started. And then I stop talking. And I give you a chance to absorb that. And what most doctors do is keep talking into that bad news, because we feel so badly having had to give bad news that we want to say, but I'm thinking of sending you to Mayo Clinic for this XYZ, or we could try some radiation therapy, or it's in a desire to blunt the impact of that news that doctors keep talking. And of course the patient isn't hearing anything after you've said your tumor is progressing. And so that what feels interminable to the doctor, which is probably 5 or 10 seconds at most, is crucial for the patient to take in the information, feel it, and begin to articulate what they want to know next. So that's the point at which I always make sure I have water in the room, that I have Kleenex in the room, and wait for the patient to talk. And they will talk. They'll say, what are our next steps, doc? Or there must be something else we can do. Or I was feeling that. That's what I was feeling. Most people know, like I said, whether they're admitting it to themselves or not. So what they say next then determines again. So if the patient says, oh, there must be more treatments out there, the response is, I wish there were effective treatments for what you have. So you are not arguing with them, because of course you wish there were effective treatments. You are on their side. But saying, in my professional judgment, there are no other effective treatments to try. And then when the patient comes back, and a small percentage come back and say, I'm a fighter, I don't care how experimental it is, I don't care how low the odds of helping me or what effect on my quality of life this is going to have, I want to pursue experimental treatment. I will then help them go to the NIH website, clinicaltrials.gov, and look to see if there are trials they would be eligible for, and show them that I will support them in what matters most to them. But at the same time, I will then say, given what we know about this illness, I'm interested in understanding what is most important to you. Now, we might have years left, we might have months left. It's hard to say, but tell me what matters most to you and your family, given that time is not going to be long as we had hoped. And that's a completely different question, right? Because when you frame it that way, up comes the fact that you haven't spoken to your son in 30 years. You had a falling out with your son over his girlfriend or his drug use or whatever it might be, and you've been estranged. That's what will come up. I haven't spoken to my son in 30 years. What an incredible gift I am giving you by giving you the opportunity to reflect on relationships that are not healed, work that is not done, that we all think we can deal with at some other time. Not today, I'm too busy, I have to go grocery shopping, I have to do the laundry, I have to pay the bills. But by focusing our collective minds on the reality that time is not infinite, it enables you to prioritize how you spend that time. And very often people will say, my priority is to spend as much time as I can at home with my family. Or my priority is to take my wife on that cruise I've been promising her for 10 years. My priority is to spend time with my grandchildren. Because time is not infinite. And when people are aware of that, they do make good choices about how to spend their time. A very small fraction will choose to be in a hospital for the rest of their life pursuing experimental treatment. And if that's what they want, we will support that. But they need to know what the trade-offs are and be making an informed choice, as opposed to, we're going to give you experimental treatment as if somehow that will buy them the time they need to spend with their grandchildren later. If you're not framing it in reality, how can they make an informed choice? And then there's a pause. Again, more pause to allow things to percolate. And I'll ask the person to tell me back what they understood from our conversation. I'll say something like, I'm a doctor, I use a lot of jargon, sometimes I use language that I understand that regular people don't understand. I'd appreciate it if you could tell me back what you understood from what we just talked about so I can make sure that I was clear. About half the time they didn't get it. Either because they couldn't hear it or because I did use expensive words that I shouldn't have used, or because the emotion flooded the ability to take in the information. And that's why doctors say, oh, I told him. And the patient said, no one ever told me. And the doctor thinks, I told him. But the doctor never checked to see what the patient actually took in and was able to comprehend. And sometimes if people can't, because they're flooded and they're terrified or they're sad, I just set up another appointment. So, this has been a great start on this conversation. I'd like to see you in the office next week so I can help you focus on what is most important to you. And I can't do that unless I know what your top priorities are. And what does that signal? That signals that no matter how sick you get, how close to death you are, I am with you. I am not leaving. I am on your side. I'm walking with you. I'm on your team, no matter what. Critical message. What happens in, mainstream subspecialty medicine? You're not responding to my chemo, I send you to hospice. I send you back to your primary doc. It's abandonment, and it feels like abandonment to patients and families. I have had many patients I've taken care of whose greatest source of distress in their last weeks of life was that their oncologist had not come to visit and had not called. And they thought their oncologist cared about them. And they're not thinking about their estranged relationship with their mother. They're thinking that this person in whom they entrusted their health and well-being for so many years that they thought really cared about them must not have cared about them. And on the flip side, the oncologist is grieving and has PTSD from so many losses of people that he did care about a lot and does love. And it would be so simple if the oncologist just stayed around and said, I really have appreciated the opportunity to be your doctor and care for you. It's been a privilege caring for you. I'm going to keep caring for you in any way that I can to support you, come what may. Then the patient knows, yes, my oncologist really does care about me. And the oncologist knows that he has more to offer than chemotherapy. It's about love. And it's about prioritizing that, prioritizing relationship. Because that's really what healing is all about. None of us are going to live forever. But if we train clinicians that their obligation is genuine loyalty to the patients who trust their lives to them, doctors are not technicians. We're not like the auto repair people. I only do mufflers. But that's how we're acting. And in our defense, I will say that's how we were trained to act. To be technicians who have a skill at a specific technique, and that's our only value. But of course that's not our only value. And I don't think most of us went to medical school thinking we were becoming glorified technicians. But the training kind of beats that out of you. So we need to get back to that. We need to get back to the relationship and support of and prioritizing of the relationship as really the highest measure of quality in the healthcare system. And that's our challenge going forward. So what would happen if I didn't take that chemotherapy? Number one has to be that I will still be your doctor. And you and I will work together to give you the best possible quality of life for as long as possible. There are lots of other things we can do that don't include chemotherapy. That means me, the oncologist, has to be trained that in fact there are lots of other things we can do, has to be trained that I have more roles than the administration of chemotherapy, has to be trained to walk with people during an illness where my treatment is not like, what I've been trained to do is not likely to help, so I need to have other arrows in my quiver. And we don't have doctors that are trained like that right now, so we have a big gap to fill. But really the truth is the most important healing and the meaning and the sense of being cared for comes from the relationship, not the chemotherapy. And we've sold ourselves short as a profession. And I think this is why so many doctors are so burned out, so exhausted, and there's so much mental illness among doctors and so much substance abuse among doctors. Because the thing that makes the work meaningful and such a privilege has been tossed aside. And how did we let that happen?